In this section, we are going to focus on tissue repair. Now, with tissue repair, we have two possibilities. We have regeneration and fibrosis. What's the difference? With regeneration, the dead and or damaged cells are going to be replaced with the exact same, or as close as possible, type of cell as possible. This is actually how most of your skin injuries heal. They are replaced by the squamous epithelial or stratified, if it's deep enough, epithelial tissues. The liver is another organ that is able to regenerate very, very well, replacing the cells that are damaged. Now, with both of these, there does become a limit. Too much damage, too frequent of damage. For instance, you sunburn every other day or every other week. You are an alcoholic in regards to your liver. That is constant chronic damage that the liver and or the skin, depending on which organ we're talking about, can only cope with and regenerate from so well. So that's where we start to get some errors in that recode process. Now, fibrosis, on the other hand, is what much of our remaining tissues do. This is the replacement of damaged tissue with scar tissue and is composed mainly of collagen that is produced by those fibroblasts. So this is produced by the connective tissue. This collagen web, the scar tissue, is going to help hold the organ together or hold the tissue together, but doesn't actually restore normal function. Examples of this would be if you have a severe cut or burn. It doesn't actually replace the skin, you get that scar. Muscle injuries, when they heal, they're replaced with scar tissue. Scarring of the lungs, when you have tuberculosis or chronic bronchitis or emphysema or anything where we have damage, we're going to have fibrosis, not regeneration, for the most part. Now, this is stages of healing a wound to the skin. There is some crossover with healing a wound pretty much anywhere else in the body as well. The same general concepts will carry over. The exact details, though, will be a little bit different depending upon the organ that we are talking about. So first and foremost, we're going to have a severe cut. This is going to sever blood vessels, which is going to allow the blood to enter the cut. So this is when we start bleeding out. Mast cells and cells damaged by the cut are going to release histamine. This histamine is going to dilate the blood vessels, causing them to expand. This is going to increase blood flow to the area, and this might seem like a contrary action, because if I have more blood flow, in theory, I can bleed out more. Except for one thing, which I'll get to in just a second. So, blood flow increases, capillaries become more permeable. This means that more white blood cells and other cell components are going to be able to leave the capillaries much easier. We're also going to have more fluid coming into the area too. Fluid from the blood itself, the blood plasma. That blood plasma is going to seep into the wound, carrying antibodies, clotting proteins, and blood cells. Okay, here's where I say this seems contraindicated. I can't talk today, apparently. You know what I'm trying to say. When the blood increases into the area, yes, we are going to temporarily bleed out a little bit longer, but what that's going to bring is those clotting factors. So we're going to get a blood clot that forms, and it's going to loosely knit the edges of the cut together and interfere with the spread of any pathogens. Because remember, any cut in your skin is a potential opening for bacteria and viruses to get in. So we want to immediately close those. This blood clot is going to do that. Now, the blood clot is temporary, and then over that blood clot, a scab is going to form. And this scab is going to seal the wound and officially block infection. Beneath that scab, macrophages are going to work to clean up tissue debris. We're going to have some new capillaries that are going to sprout from nearby vessels and grow into the wound. Deeper portions of the clot are going to become infiltrated by those capillaries and fibroblasts, and we're going to transform that bottom portion, the deep portion of the clot and scab, into a soft mass, which is referred to as granulation tissue. The rest of the blood clot is going to be removed by the macrophages, and fibroblasts are going to secrete collagen fibers to fill in that space where that clot was. We are then going to have surface epithelial cells around the wound. They're going to start to multiply and migrate into the wounded area beneath the scab and on the edges of the scab. This is why if you've ever looked at a cut, especially if you're someone who likes to pick at scabs, we've all been there. If you look at a cut, it is going to seem to kind of shrink. And that scab seems to get smaller and smaller and smaller. And that's because they're growing up underneath and they're growing in from the outside. That's also why larger wounds take longer to heal. We have to connect the edges, and if it's bigger, it's going to take longer to connect those edges. This is a concept that's going to come back into play later in this unit when we get to the skin and we get to the end of the skin portion where we talk about some disease conditions of the skin, specifically burns. And we talk about first, second, and third degree burns. And then the rule of 9 and why all of that matters. This concept of the epithelial is growing up and in comes back to play in that, and why we grade them and why we do things like skin grafts and stuff like that. All right, so eventually the scab is going to loosen and fall off. The epithelium, though, is still going to grow thicker and it's going to regenerate itself. Now, that's going to be this top layer of the skin. The connective tissue underneath in the dermis layer, that is going to undergo fibrosis. That is not going to repair itself. There are a variety of things, though, that are going to affect repair. First and foremost, nutrition. If you do not have specifically adequate protein, but it's going to be all nutrition as well. But if you definitely don't have enough protein, you are not going to be able to do this repair process. It's going to be very, very slow. It's going to take a long time. You're going to end up more with fibrosis than regeneration. This is a energy and nutrition dense process. So if you're going in for major surgery, for instance, whatever it may be. Maybe you broke your leg and they have to put in pins. You broke your ankle. When you go in for major surgery, any major invasive treatment, you should be making sure both before and after you have increased your protein amount. It's going to boost healing. Things like vitamin C will also boost healing. There are 2 requirements that are very, very heavily used in this healing process. Obviously, there are other necessary vitamins and nutrients that are going to be necessary for repair. Obviously, blood circulation is going to play a role. If you have poor circulation, you're going to have poor wound repair because blood circulates oxygen, nutrients, antibodies, and other defensive molecules. It's part of your immune response. And so if the immune response can't circulate well, you're going to have a poor immune response. And then age. Obviously, young people are going to heal faster and have less obvious scars. Some of the reasons for this is they tend to have a better nutritional status, better blood supply, higher metabolism. If you have elderly family that you help take care of, or you already work in the healthcare field, especially if you work in a nursing home. I mean, older people don't eat well or much, and there's a lot of different reasons for that. One, what they can and cannot eat due to health is convoluted and complicated. Their taste buds are starting to fail, so things don't necessarily taste good. One thing I've noticed is they tend to have a very large sweet tooth. So typically most sweets, unless they're eating like fruit, don't have a ton of nutrition. It's calories, but they're not getting a lot of bang for their buck. And then the most important thing is they tend to have poor oral health. They are missing teeth or have dentures, and maybe the dentures don't fit well. There's a bunch of different things that are going to impact what they can and cannot eat, how they eat, if they want to eat. Some medications actively suppress the appetite, and so even though they need to eat, they don't feel hungry. Or it could be the reverse. So there's a lot that goes into this. All right, some conditions. We're going to talk about conditions here, there, and everywhere. Some of these are going to be system specific, and some are going to be more what we refer to as system generic or systemic conditions, meaning they affect more than one system. The reason we're talking about systemic lupus erythematosus, otherwise known as SLE right here, is because this is an autoimmune condition that is systemic. It affects more than one system, but specifically it goes after connective tissues. It is the connective tissues that are affected in this condition. Epithelial tissue is also affected here. So that's why you get that characteristic skin rash, that butterfly rash that you see right here across this poor girl's face. You get generalized weakness, tiredness. You'll hear these throughout your healthcare career. There are 5 symptoms that, we note them down in the patient chart, but in and of themselves, they don't really mean anything because a lot of diseases have them, share them, and a lot of drugs have them as a side effect. What are they? Fatigue, muscle weakness, nausea, vomiting, and then diarrhea, constipation. Fever also came thrown there, although fever we do pay attention to because fever is your body's response to an invasion. It's trying to cook out what's invading it. So we do pay attention to fever, but it is also kind of lumped in on, okay, fever in and of itself doesn't really tell us much. Some of the other common symptoms of SLE is arthritis. Usually mild, but arthritis nonetheless. For anybody who's going into radiology, depending on how far you are going to go, one of the things that you will learn is on x-rays, different types of arthritis, whatever the plural is, will present in unique patterns. Now, will systemic lupus erythematosus always present exactly the way it's supposed to on x-ray? No, because humans are unique and rare and everybody is different. So everybody presents and shows a little bit differently. But there are some general things that they typically will present with. If a patient has psoriatic arthritis, they will tend to present a specific way in imaging. If it's osteoarthritis, again, it tends to be a different way. Gout, rheumatoid arthritis. They all tend to have slightly different presentations, and you can use that to help determine, is this SLE? Is this OA? Is this psoriatic? Is it RA? What type of arthritis are we dealing with? All right, rare symptoms are going to include things like hair loss, mouth ulcers, headaches, poor circulation in the fingers, with more serious complications being affected in the kidneys, heart, and brain, specifically inflammation. Think about where you have epithelial tissue. Think about where you have connective tissue. And you will start to see why this is so problematic. Now, systemic lupus erythematosus is going to typically be found and diagnosed more in women, about 9 times more likely, and about 4 times more likely in our African American population. So there does seem to be a genetic component, specifically to the X chromosome and specifically to the marker that is unique to this ethnicity, kind of like sickle cell. But that does not mean a white man cannot have SLE. They absolutely can. It's just the probability is higher in these two populations. Why do I point that out? Because I actually had a patient who, white male, diagnosed with systemic lupus erythematosus, which is traditionally more of a African American and female condition. He was also diagnosed with rheumatoid arthritis, which is also more of a feminine condition, more likely to be diagnosed in women than in men. So we will touch on RA at a later date in one of these other units, but just because something is more likely to be in a certain population does not mean you can automatically rule it out of your possible diagnoses. That's really where I'm going with this. We have things like Marfan syndrome. Marfan syndrome is a genetic disorder that encodes the fibrillin protein. And this means it's going to be a connective tissue disorder. Those with Marfan syndrome tend to be very, very tall and thin. Their arm span is typically going to exceed their height. So if you stand up and you put your arms out to your side, and you were to measure from fingertip to fingertip, that should be roughly equivalent to if I were to measure your height. In Marfan syndrome individuals, that length will be longer. These individuals also tend to have long thumbs, as you can see here. This is a typical sign of Marfan syndrome. These patients are very, very prone to scoliosis, as you can see in these two pictures right here. These patients are also going to tend to be more prone to things like pectus excavatum. Basically, it's a chest deformity where their chest kind of caves in a little bit. These patients tend to also be more prone to heart disorders. There's actually some discussion, is that probably the best word, in the historical community that Abraham Lincoln may have had Marfan syndrome.